Hello. Today we are going to look and talk about joints. We're going to look at all the different joints in the body and the different classifications of joints that we have throughout the body as well. So joints, they're also called articulations. And an articulation is where two or more bones meet. So joints give us mobility. They let us walk. They let us pick things up. They let us hold on to something. They hold the skeleton together. We have a structural classification of joints and a functional classification of joints. Joints can be either fibrous, cartilaginous, or synovial, and they can be synarthrosis, amphiarthrosis, and diarthrosis. So they could be immovable, synarthrosis, amphiarthrosis, or slightly movable or diarthrosis. Freely moving, like your arms, your shoulders. So let's look at a fibrous joint. A fibrous joint, we kind of looked at those when we looked at the appendicular skeleton. We looked at between the radius and the ulna. That's a fibrous joint because it's a layer of dense fibrous connective tissue. There's no joint cavity there, so they're not really movable. Let's look at the types of fibrous joints. Sutures. Sutures are what make up most of the joints in the skull. So like that coronal suture, that sagittal suture, that lambdoidal suture, that all of those sutures in the skull, they're technically a type of joint, but they are immovable and they just join the skull into one unit. So sutures can also be called synostosis. So here are sutures. Sutures are the ones found in the skull, and they have fibrous connective tissue that joins one bone to the neighboring bone. Sutures are only found in the skull. Let's look at a syndesmosis. A syndesmosis type of a joint is connected by ligaments. In a ligament, we kind of looked at them when we looked at tissues, but a ligament is fibrous tissue, just a band of fibrous tissue. So there's two different kinds of syndesmosis. They can have short fibers that offer little to no movement, like where the tibia and the fibula come together down close to the ankle, because that is a syndesmosis, so the inferior tibiofibular joint. Or we could have long fibers, then they allow more movement. Like the syndesmosis that's between the radius and the ulna, it still allows movement because you can pronate and supinate your arms. So here's that syndesmosis at the talofibular joint. You see the tibia and the fibula, where they come together, forms this syndesmosis. How about a Gamfosis? This is your teeth, because it's like a peg in a socket type of a joint. So if you've ever played little games where you stick pegs into holes, that's what a Gamfosis is. So, of course, in the human body, the teeth are the only alveolar, in their alveolar sockets, they are Gamfosis joints. And your teeth are held in place with a periodontal ligament. So here is a tooth in a Gamfosis. We have our periodontal ligament that holds your teeth in. And a peg and socket type of fibrous joint known as the Gamfosis. Let's look at cartilaginous joints. In a cartilaginous joint, you think cartilaginous, so they must have cartilage. Well, they do. But there's no joint cavity to these. So they're not very movable. So we have a synchondrosis and a symphysis. Let's look at the synchondrosis first. Their hyaline cartilage kind of unites bones. So most synarthrotic joints or synchondrosis, they're not movable. So the cartilage between the ribs and the sternum, those are synchondrosis joints. Even the epiphyseal plate is technically a synchondrosis because here at this growth plate or epiphyseal plate, it's cartilage, it's hyaline cartilage, and that hyaline cartilage is turning to bone as it continues to grow. Symphysis. First thing you should have thought of when I said symphysis would be the pubic symphysis. That pubic symphysis is, of course, a symphysis joint. It is made of fibrocartilage. Well, fibrocartilage, well, that's your intervertebral discs too. So both the intervertebral discs and the pubic symphysis are fibrocartilage. Symphysis joints are very strong. They're amphiarthrotic. So they move slightly. They don't move a lot, but they'll move a little bit to let your pelvis kind of move around, and they let your back move, you twist and turn. So symphysis joints they're slightly movable, but they still kind of hold everything together really well. Like the fibrocartilage here in this intervertebral disc. Or this pubic symphysis. Those are all both symphysis types of joints. Synovial joints. Synovial joints are freely moving. They're probably the most abundant type of joint in the body. We talked about with tissues. In a synovial joint, they have synovial fluid in a synovial cavity. They are diarthrotic or freely movable. As I just said, it makes most abundant joint in the body, so it's pretty much all your limb joints, fingers, toes. So they have a bursa and a tendon sheath associated with them. They need stability. They allow several planes of movement. Think, how many directions can you move your arm or your leg? Several. So there's 6 different kinds of synovial joints. Let's look at the different kinds, or what they're made up of first. So there's 6 features to them. They have articular cartilage. So they're going to have cartilage on each side of whatever bone joint they make. So my little joint here, they're going to have cartilage of some sort covering the bone. They are going to have a joint cavity. They've got some kind of cavity here around the joint. That articular capsule, I do the first layer of it, but it is 2 layers thick. Then it is filled with synovial fluid. That synovial fluid is made of hyaluronic acid. That hyaluronic acid contains phagocytic cells to remove microbes and debris from that joint cavity. The last thing we want is an infection in our knee joint or our fingers or shoulder or hip. There's different kinds of ligaments that help to reinforce the joint. Let me redraw my joint here. Part of the bone and then part of another bone together. Like this, if this was my knee, they have ligaments right here, right here. They have the patellar tendon that comes down, attaches to that tibial tuberosity with the patella in the tendon. There is also behind the patella, there's ligaments that go this way, ligaments that go this way. So there's a lot of things that are holding the knee joint together. We have to have nerves and blood supply in a synovial joint because we need something that detects some kind of pain. It would be bad if you hurt your knee, but you didn't even know it. Also has to monitor position and stretch. You can't overstretch a joint because that can cause problems. If your knee is sitting in some weird position, that would be really painful. We need capillary beds. So those really small arteries, we get those arteries, and it branches off into many directions, and they These are our capillaries that then turn into veins. So we need those capillary beds to kind of filter that synovial fluid. Supplies that filtrate, so that liquidy substance that is in that synovial joint. So here's the drawing from the textbook, probably much better than mine. But it shows how we have ligaments that help hold the joint together. We have a joint cavity with synovial fluid. We have that articular cartilage, and in that capsule for that joint, you have a fibrous layer and a synovial membrane. And then you have your bone on the other side of that whole joint. So sometimes, depending on where it's located, we have fatty pads. These fatty pads are kind of like a cushion. They're between those fibrous layer of the capsule and the synovial membrane of the bone. So you actually have fat pads behind your elbow up a little higher to help kind of protect a little bit. Or they can have articular discs. It's usually fibrocartilage, like the menisci in your knee. Those are articular discs. Those are the menisci. They help to protect the joint. They help to stabilize your joint. They protect from wear and tear as well. It's kind of important. So a bursa. We've talked a little bit about, we mentioned it, but here we're going to talk what it actually is. A bursa is a little fluid-filled sac that reduces friction. It could be by ligaments, muscles, skin, tendons, or where bones rub together. There could be a bursa to help kind of protect, let things flow smoothly. We also have tendon sheaths. Those are more elongated bursa that wrap around tendons. Like your shoulder has one. Here's your shoulder joint. We have two different bursa here. We have a subacromial bursa. If you remember that acromion, the acromial process of that scapula here that articulates with the clavicle, well, just below that, there's this bursa here in green. We have our biceps muscle in the front of our arm. If you're in the anatomical position, is the front of your brachium or is in the front of your humerus. Well, when that tendon comes up into the shoulder to attach at the top, it has a tendon sheath or a bursa that helps to let that tendon glide more smoothly in your joint as you do things. So let's look at what can affect the stability of our synovial joints, because there's a lot. So what the shape of the surface? How well do the bones fit together? Like in your shoulder, that's a shallow surface that they fit together on. So it's not as stable as, say, your hip. Your hip, where the femur attaches to that os coccyx bone, is a deep ball and socket. That is very stable compared to your shoulder. Ligament number and locations. We have a lot of ligaments that cover joints and help to hold the joints together, especially in our shoulder. So we have the more ligaments, the more stable the joint. That's important. It helps us move our shoulder around without letting that head of the humerus come out of that joint. Muscle tone. So muscle tone plays a huge role in the stability of joints, like our shoulder. There's several muscles and your knee that hold your humerus to your shoulder or to that scapula. There's a lot of muscles. Just like in the knee, there's a lot of muscles in there to hold things together. We looked at the arches of our feet in the appendicular skeletal lecture. There's a lot of muscles on the bottom of your feet, very small muscles, but they do a great deal to actually help hold the arches of your feet. So I included the chart from your book here. Talks about what kind of joint. We have a fibrous suture for our skull. It's for cranial and facial bones. There's synarthrotic, so there's no movement. The temporomandibular joint. There's synovial there, kind of a hinge joint, but it's diarthrotic, so it moves freely. That lets you open and close your mouth. So this whole chart goes through all of the main bones. This one's the upper body. This is the lower half of the body. Goes through every joint, what the joint name is, what bones articulate with what type of joint it is. It even talks about the planes. We'll look at the planes of joints here shortly. And whether it's diarthrotic, amphiarthrotic, or synarthrotic. So that's all available on these charts for you. So our synovial joints, some of them move in one plane, some of them move in several planes. So we'll talk about it more when we get to muscles, but all muscles in the body attach to a bone or connective tissue. And they usually connect it at least two places, sometimes more. So our origin for those muscles is the attached part, and it's not movable. But the insertion is the movable part. So if you think about your biceps and your arm, it attaches to your shoulder, but your biceps doesn't move your shoulder. Your bicep lets you bend your forearm up. So the insertion is down in the forearm. So that'll allow you to move. That's what allows you to move your arm. So this lists the planes. It's either transverse, frontal, or sagittal plane is how joints move. So let's look at the different kinds of movement. We have non-axial. So they kind of just slide back and forth. We have uniaxial. Uni is one, so it moves in one plane. Biaxial, bi is two, so two planes. Multiaxial, multi, so there's many, or all three planes. We can have gliding, angular, or rotational movements. So, gliding movements. It's where one flat bone glides over the surface of another bone. So, intercarpal joints. Carpal are your wrist bones. So your carpals, your wrist bones slide or they glide over each other. Same with the intertarsal joints. The tarsal is the bones of mostly your ankle. They glide over each other. The articular processes of the vertebrae. So again, if you think of the superior and inferior articular facets of the vertebrae, when they're together, they slide back and forth to allow you to move. Let's look at angular motions. Angular motions do just that. They increase or decrease the angle between bones. There's different kinds of angular movements. There's flexion. So flexion, if you think for flexion, if you bend down and try to touch your toes, that is flexion. You are bending forward. Extension. It increases that angle of the joint. So extension, if you bend back. But hyperextension goes beyond anatomical position. So if you bend your head back as far as it'll go, that's hyperextension. Abduction. So if you're standing with your arms at your sides and you take them straight out, following that frontal or coronal plane, but taking them away from the body, that is abduction. Well, adduction brings it back down to closer to your body, still moving along that frontal or coronal plane. That is adduction. Circumduction. Circumduction, it involves flexion, abduction, extension, and adduction of the limb. So circle, it's moving your arm, say, or your leg in a circle. That is circumduction. So here's gliding. Your wrist goes back and forth. That is gliding. So flexion, I said, is either bending forward or even looking down is flexion. Extension is bringing your head back. Hyperextension, especially of your neck, is bending your head back as far as it can go. Here is flexion, extension, and hyperextension of someone standing. As I said, abduction takes your arm straight out to the side away from the body, while adduction brings it back down. Circumduction is moving your arm or your leg in a circle. Let's look at rotation. We talked about this a little bit when we talked about C1, C2, and the spine. So rotation, C2, remember, is the vertebrae that lets you say no. That is rotation. So we can have medial rotation, which is rotation towards midline, or lateral rotation, which is rotation away from midline. So as I said, we can rotate our head to say no. We can rotate our legs to turn out or back turn in. That is rotation. Pronation and supination. If you have not done this with the skeletons in the lab, you really should, because it's kind of cool to see what happens to the radius and the ulna when you pronate and supinate. So supination, remember, has the word up has the word up in it. So that's when your hand is up. Pronation has the word on. So that is when you're on or hand is facing down. So when you're supinated, your radius and your ulna are parallel. But when you're pronated, that radius actually rotates over the ulna. When we're talking about our feet, we have dorsiflexion and plantar flexion. Dorsiflexion is when you kind of flex your foot up, your toes are going towards your shin. But plantar flexion is if you point your toes down towards the floor. So here's kind of what you see when you do pronation and supination, how that radius actually rotates over the ulna. It's kind of cool to see on the skeletons in the lab because they do this. Well, dorsiflexion is flexing your toes up, and plantar flexion is pointing your toes down towards the floor. Our feet can also do inversion and eversion. Inversion is when you take your foot and point it medially. Well, eversion is where you take your foot and point it away from you, so it goes out lateral. We have protraction and retraction. You can do that of your jaw, your mandible, where you jut your jaw or mandible out forward away from you. That is protraction. While retraction is you take your mandible and move it back towards your neck. So here is inversion, your foot towards the center. Eversion, your foot goes away. And protraction, her mandible is going out. And retraction, she's pulling it back in. We can also elevate and depress. So you can do this with your shoulders, your mouth, because you can, elevation is lifting something. So you can lift your shoulders up. And then depression is when you drop them back down. Every time you open your mouth to talk, to eat, to whatever, you're depressing that mandible. It's going down. Apposition. This is a movement of the thumb specifically. You can take your thumb and touch the tip of the other 4 fingers on that same hand. That is opposition, and that's what allows you to hold something. Hold a pencil, a pen, your phone. That's all opposition. So here is elevation and depression of the mandible. Well, opposition, taking that thumb and touching the tips of each of the fingers. So here's all the different movements in a table for you with all of the definition for each of those. So let's look at the different categories or the types of synovial joints. We have a plane, which is a flat surface. This again is in your carpal bones, and they glide back and forth. So her plane, flat articular joints, and they just glide back and forth. A hinge. When we looked at the appendicular skeleton, we looked at how the ulna and the humerus come together and how that ulna has that little cup that grasps onto the humerus. That allows your elbow to hinge. It only moves in one direction. You can bend it and straighten it. Pivot. I also talked about how that radius and that ulna are connected together. Well, when you pronate and supinate your forearm by taking your hand up and down to the floor, then back up, then down to the floor, that is a pivot joint because that radius here is pivoting around the ulna. Now in our metacarpophalangeal joints, we have condylar joints. So, as you can kind of see here, the first part is more rounded, while the other side has more of a divot in it for that joint to fit in there. Those are condylar joints. They're biaxial, so they can, like your fingers can move. You can bend your fingers forward and back, and you can adduct and abduct. So you can spread them apart and put them back together. Saddle joints. So this is the carpometacarpal joint of the thumb. That is a saddle joint. So this bottom part is more rounded down, while the top part kind of fits right over top of it. This is also a biaxial because you can bend your thumb and you can abduct and adduct your thumb. So it moves in two directions. Now a ball and socket. This is how your humerus fits onto your scapula. You can see it's not very deep, but it allows you to go through, bend, take your arm straight forward up in front of you and back down and even back behind you. It can abduct away from you and adduct back towards you, and it can rotate. So ball and socket joints are multi-axial movement. So we have lots of different synovial joints throughout our body. Let's look at each of them. We have our Temporomandibular Joint, or TMJ. It's technically a modified hinge joint because that mandibular condyle articulates with that temporal bone. So it has, because it's a synovial joint, so it has an articular capsule with a lateral ligament. Lateral, so it's on the outside of the joint. The temporomandibular joint is a hinge. It can depress and elevate, but it can glide side to side. That's what allows grinding of your teeth when you're really stressed, or could be just some childhood habit that kept up going. But that's what lets you chew your food too, is that gliding and hinging of those joints. The temporomandibular joint is technically it's the easiest to dislocate in the body. Not a good thing, but as long as you're kind of careful with it, it's fine. So here is that temporomandibular joint. You see this articular capsule through here with the ligaments helping to hold this joint in place. And that's between the mandible and that temporal bone. Here's another view, kind of a slice right through the joint. You see that synovial membranes You see how everything kind of glides nice and easily back and forth over that joint. So, some people get that dislocation of the TMJ. It's a very shallow socket, so that's what causes it to happen. You usually need a physician to put it back into place. If somebody's temporomandibular joint is causing pain, they usually have ear and face pain. Their muscles are sore. They'll have some kind of popping and clicking sound when they open their mouth. If you watch them open and close their mouth, you'll usually see some kind of deviation to the side as well. Kind of interesting to watch. They usually have stiffness in their jaw. And as I said, it's caused by grinding of teeth, but it could be due to trauma. So they usually get some kind of bite plates and work on relaxing the jaw muscles, because their jaw muscles are usually over tense, and that can cause some of the problems as well. So that glenohumeral joint, or that's your shoulder joint. It's known as the glenohumeral joint. So it's freely moving. It moves in all directions. But our stability is lost because we have so much movement that it's considered a ball and socket joint, even though that little cup in the scapula is not very deep. This is what your books kind of said. It's kind of like a golf ball on a tee. The tee doesn't have a very deep groove in it for that golf ball to sit on, so it can easily be hit off. There's several ligaments and muscles that help to hold it together, so it is held in there with an articular capsule. It's kind of thin and it's loose, and that's what allows it to move so freely. So you've looked at this once already. So here's our shoulder joint. We have several tendons. We have this articular capsule that helps to hold this whole joint in place. We have the coracohumeral ligament that helps to hold this in place. We also have this fibrous layer of the articular capsule that holds it in place. Here is a cadaver photo of a shoulder. You see the articular cartilage on each of the two bones here. You see that articular capsule, and you can even see the space in here that could contain synovial fluid. It won't in a cadaver, but it will in a live person. So let's kind of look at some of the ligaments that hold that shoulder in that humerus to that shoulder joint. The main one, we have a glenoid labrum. That's another place that has fibrocartilage. It has a fibrocartilaginous rim and is kind of around that glenoid cavity. So that glenoid labrum actually helps to make the cavity where that humerus fits in a little deeper to kind of help hold it in place better. But it only holds about 1/3 of the head of the humerus. So we have that coracohumeral ligament. These ligaments are named for where they start and where they end. So coraco, that coracoid process. Humeral, oh, it goes to the humerus. coracoid process to the humerus. That's where the ligament goes. Glenohumeral ligament. So the gleno, okay, it attaches to that glenoid cavity or that glenoid fossa. Humeral, well, it goes to the humerus and it's another ligament. That's at the anterior. And it kind of helps support that coracohumeral ligament supports the weight of the upper limb. So they're kind of do a lot. So here's that coracohumeral ligament. Goes to that coracoid process and it connects to the humerus. We have those glenohumeral ligaments. Gleno, so they go around that glenoid cavity and they attach to the humerus. A lot of times the ligaments are named for where they start and where they finish. It's kind of nice. So here is what your shoulder looks like if you're looking straight on. You see all these ligaments, you see this articular capsule through here. There's a lot going on to try to help hold your shoulder in place and give some sort of stability to your shoulder. We also have muscle tendons. So not just ligaments or tendons, but on their own, we have muscles that usually have tendons that are the parts that attach to bone. So biceps brachia, I've mentioned that a couple times. The long head, there's two different heads. Bi means two, so there's two heads to the biceps muscle. That is called the superstabilizer, that long head. As I've said, with that intertubercular sulcus, it's named because something goes through there. Well, it's the tendon to the long head of the biceps brachii. And it kind of helps hold that glenoid, the humerus to the glenoid cavity. We also have the four muscles that make up the rotator cuff. It's their tendons anyways, but they're connected to the muscles. So we have subscapularis, supraspinatus, infraspinatus, and teres minor. These are all muscles that are on or around the scapula that attach somewhere on that shoulder joint. So you can see they cut them off, those rotator cuff muscles, how they help to protect over that joint. That's important. It helps keep everything together. We can see that head of the humerus, but we also see that capsule of the joint. That's also cut open, so we can see what's going on in here. Even the acromion was cut, so we could see what was going on. You see there's lots of muscles and there's lots of tendons and ligaments around. Shoulder dislocations. It's actually a common sports injury. Because, again, that cavity is not very deep. So, as it says, structures reinforcing that glenoid cavity are weakest anteriorly and inferiorly. So those are the two directions that your shoulder dislocates the easiest. So, and when you rotate laterally and abduct, like football players when they tackle, that's can cause a shoulder dislocation pretty easily. If you get hit on the top of your shoulder, that can dislocate it. If you get hit in the back of your shoulder, that can dislocate it. So shoulder dislocations are not uncommon, and they usually need some kind of medical professional to help put them back into place. Elbow joint. So our elbow joint is, of course, where the radius and the ulna articulate with the humerus. I already mentioned that your elbow joint is a hinge joint. So that's what lets your arm only moves in one plane of movement. But it's that trochlear notch that articulates with the trochlea. So that's how the ulna, that trochlear notch, which is that little cup on the ulna, articulates with the trochlea of the humerus. So we can flex and extend. There is what's called an annular ligament that wraps around the head of the radius, because the head of that radius is just a circle all the way kind of around. So there's a ligament that attaches around that. Then we have what are called collateral ligaments. Ulnar, so it's on the ulnar side, ulnar collateral ligament, and radial. Well, that'd have to be on the radial side for the radial collateral ligament. So let's look. Again, we have that articular cartilage. Of course, we have to because it's a synovial joint. You have your ulna. You have your humerus. So you see we have little fat pads on both sides of the joint. You also have a bursa in the back of your elbow there. But you can see the different muscles and tendons because you've got the triceps muscle in the back and you have the biceps muscle in the front that's helping to reinforce that joint. Now let's look at the ligaments. This annular ligament right here is what's wrapped around the head of the radius. Then our collateral ligaments, it attaches the radius to the humerus. So here's another view. You see that annular ligament on this cadaver. You have the ulnar collateral ligament because that's attaching the ulna to the humerus in 3 different places. So here's a drawing of just that. Again, that annular ligament that is wrapped around the head of the radius. And you have your ulnar collateral ligaments helping to hold that ulna to the humerus. Let's look at our hip, or the coxal joint. That's another ball and socket joint we looked at when we saw the appendicular skeleton. That is where the femur articulates with that acetabulum, the acetabulum. We have a lot of motion with our legs, but it is still kind of limited because you can't kick your leg up next to your head. Most people cannot because of the restriction in that acetabulum. We also have an acetabular labrum. Again, fibrocartilage that makes that deep socket even deeper. That's why hip dislocations are so rare, because that deep socket is made even deeper. So we have that acetabular labrum, that's that part in red. We have the ligaments, or the articular capsule that connects everything together. We also have a ligament of the head of the femur. That actually helps to attach the head of the femur to that hip bone. So here's another view. This isn't a cadaver. So you can see that synovial membrane, that acetabular labrum. You even get to see the ligament of the head of the femur in this view. It's a pretty good cut. You even see that articular capsule that helps hold everything together. So just like the shoulder, we have several ligaments that help to reinforce that joint. And again, the names tell us the 2 bones that they articulate with. We have iliofemoral ligament, so the iliacus to the femur, pubofemoral ligament, the pubic bone to the femur, ischiofemoral ligament, ischium to the femur, and then again, as I pointed out in those pictures, the ligament of the head of the femur, or it's called ligamentum teres. So this joint has the most stability for a ball and socket. Comes from that deep ball in the socket. That's where that stability comes from, and then the everything that helps to hold it in place. So from this view, we see the iliofemoral ligament. Ilio goes from that ilium to the femur. We have the ischiofemoral ligament, so that ischium to the femur. From this view, we see the iliofemoral ligament here. There's several. It goes from that ilium to that femur. And the pubofemoral, pubic bone to the femur. That's all holding your head of the femur to that hip joint. Knee joint. Your knee joint is known as the femoral patellar joint. Femoral, femur, patellar. So the femur that articulates with the patella, that's one of them. It's a plane joint, so it kind of glides when you bend and straighten your knee. We have a lateral joint and a medial joint. So tibiofemoral, we have a lateral tibiofemoral and a medial tibiofemoral. And in those joints, we have menisci. Those menisci help to cushion and protect that joint. The medial and lateral joints allow for flexion, extension, with some rotation. Not much, but some. You can kind of see the menisci in here, but you see that patella. There's even a patellar bursa. There's a suprapatellar bursa that allows for everything to move. Infrapatellar bursa, your fat pad. Here's the deep infrapatellar bursa. There's a lot of bursas in here. We have our patellar ligament, because from our quadriceps muscles, they turn into a ligament, and those ligaments come down and attach to the tibia, but the patella actually sits in that ligament. So we have what are called cruciate ligaments. We have a posterior and an anterior cruciate ligament. That posterior, it's called posterior because it may start in the front, but it attaches in the back. And that anterior, it may start towards the back, but it attaches towards the front. Here's another view. You can see the menisci really well from here. We have a lateral meniscus and a medial meniscus. So when we look at our meniscus, this is a right knee. Well, because they told me it was medial. So if this is medial, this has to be on the right side. But knowing that that medial meniscus is much bigger than that lateral meniscus, that's huge. And then we have our cruciate ligaments in here. We also have collateral ligaments that they somewhat talk about. But that joint capsule, we don't have it in the front. We have it in the sides, in the back. Because all we have is that quadriceps tendon that gives our patella, which attaches down into the tibia. And there's actually about 12 bursa that are associated with the knee. That's a lot. So if you've ever had, I'm sure everybody's had their reflexes tested, and their knees, the knee jerk reflex, they're actually tapping that patellar ligament, and they are stimulating the nerve at L4 that comes out from your spine at the fourth lumbar vertebrae is what they are testing at that joint specifically. So here's how our knee actually looks, somewhat. Because we have collateral ligaments. Collateral, of course, is on the sides, connects the bones on the side. You have a retinaculum. You have your patellar ligament, your quadriceps ligament tendon that turns into the patellar ligament that attaches to the tibia. So you can kind of see how everything comes together. So we also have, I just showed you the fibular and tibial collateral ligaments, the oblique popliteal ligament, and the arcuate popliteal ligament. So here's that tibial collateral ligament along the side. But we have these arcuate popliteal ligaments in here. We have our fibular collateral ligament on this side, oblique popliteal ligament. Popliteal, remember, popliteal is the name for the back of the knee. So these are the ligaments that go across the back of the knee. Then those anterior and posterior cruciate ligaments. So if you've ever heard of ACL or PCL, that's a tear of those ligaments specifically. And as I said, they're named for where they attach. Anterior cruciate ligament attaches to the anterior portion of the tibia. Posterior cruciate ligament attaches to the posterior portion of the tibia. So here you see that anterior cruciate ligament and that posterior cruciate ligament. They are all holding your knee in place. Here it is on a cadaver. You can see that anterior cruciate ligament. You see that medial meniscus. We're here on the other side. This is your lateral meniscus. And here you can kind of see that posterior cruciate ligament. So knee injuries are kind of common just because people can get run into, things can get knocked from behind, even blows to the side, horizontal, coming in from the side. There's collateral ligaments that can get torn, cruciate ligaments that can get torn, or those menisci that can get torn. Those are the 3 C's: collateral ligaments, cruciate ligaments, and cartilage or menisci. Because a blow from the side, that lateral blow, can actually tear the collateral ligaments, the menisci, and that anterior cruciate ligament all in one blow. That's kind of scary. So ACL or anterior cruciate ligament injuries, if somebody is turning, if you've ever run suicides in school where you run to one end of the gym, turn around fast and run back, if you turn too quickly, it can actually tear that anterior cruciate ligament. And that actually needs surgical repair. Hockey puck. There's something that's called the unhappy triad. So that is the tibial collateral ligament gets torn, that medial meniscus gets torn, and the anterior cruciate ligament gets torn. All 3 of those gets torn by a lateral blow. That is known as the unhappy triad. Looks painful. So let's look at some of the disorders of joints. We can have cartilage tears. It's usually repaired with arthroscopic surgery. because cartilage doesn't repair itself. Remember, it doesn't have direct blood supply like bone or tissues do. So a cartilage tear could be due to compression or just stress on that joint can cause cartilage to tear. You can maybe end up with a meniscus being removed, but that kind of leads to osteoarthritis, which is degeneration of the joint. So they'll tend to do more transplants in younger people, and they're looking at actually growing a menisci from stem cells. Kind of cool. So here's a meniscal tear, and this is actually from an arthroscopic surgery. So they're sticking a little scope with a little camera into the knee. And this is what they're seeing. They're seeing this tear in that meniscus right here. This whole thing is torn. So they can go in and surgically repair this. A sprain. This is a very common injury. It's when ligaments get stretched or torn. Happens in the ankle. If you've ever sprained your ankle, the knee, even the low back. You can sprain your low back. Again, tendons, ligaments, they're poorly vascularized. So they're very slow to heal. That's why among a lot of athletes, they say they'd rather break a bone than sprain a ligament, because spraining a ligament takes longer to heal sometimes than breaking a bone. Because bones are highly vascularized, ligaments are not. So depending on what happens, how severe the tear is, they can actually sew the ligaments back together. They can graft, which means take ligaments from other parts of the body and put it in there. And just allow for time and immobilization. That one's the hardest, especially when it stops hurting. On an athlete specifically, that one's the hardest, to tell them to stop and stay stopping. Dislocations. A dislocation, again, is where a bone is forced out of alignment. So your shoulder gets out of that glenoid cavity and it's out of place. That's a dislocation or luxation. Usually is some kind of sprain, inflammation, and it causes a lot of difficulty with moving joints. Could be from a fall, sports. But if a joint gets dislocated, it needs to be reduced, which means to be put back into place. So those joints would need to be put back into place, and then they need to treat it. A subluxation. What a subluxation is a partial dislocation. So it's not fully out of its joint, it's only partially out. That is what a subluxation means. Bursitis. Again, I've mentioned this before, but it has the word itis. Itis means inflammation, and it's bursa, inflammation of the bursa. Could be caused from extra friction or some kind of blow to that area. We treat it with rest and ice, or if it's bad enough, some kind of anti-inflammatory drugs. That's usually to let your doctor decide. Tendinitis, again, it has itis. So it is an inflammation inflammation of a tendon. Main cause, overuse. Using it more than your body is trained to use it. When you're increasing activities, you do it over time, you don't do it overnight, because that can cause tendinitis. Again, rest ice, possibly anti-inflammatory drugs. Arthritis has itis, some kind of inflammation. Arthrosis joints, so inflammation of the joints. There's over 100 different types of arthritises. Some of them are inflammatory, some of them are degenerative, others are even autoimmune. They can cause pain, stiffness, swelling. Some are caused by bacteria. Osteoarthritis is chronic. Rheumatoid arthritis, that one is autoimmune. Or Gaudy arthritis. So the most common type of arthritis is osteoarthritis. That is irreversible degenerative arthritis. So could be too much breakdown of cartilage, and then the knees are the most common place for it to start. So cartilage is being broken down much faster than it's being replaced. We can also get bone spurs in osteoarthritis, and that is where the bone thickens at the end of different places, different bones. So by the age of 85, half of Americans have already developed osteoarthritis. That's crazy. And it's more women than men. That's even more crazy. The sad thing is it's usually part of the normal aging process. So joints can crunch, make noises. That's kind of referred to as crepitus when you hear noises in any of the joints. Activity, keep moving, going for walks. That is the biggest way to prevent osteoarthritis is moving, activity, exercise. Pain relievers, capsaicin creams. So there's different things that you can kind of do for osteoarthritis. Here, this is a grade 4 osteoarthritis. As you can see, these bones are right on top of each other. That has got to be painful because those bones are rubbing together. There should be some nice joint space there. This picture, there is not. Rheumatoid arthritis. As I said, it's autoimmune. Autoimmune means your body's own immune system is attacking itself. And what is happening is your immune system is actually attacking your synovial joints. So when that happens, it causes pain, it causes swelling. It's even bilateral. So you usually see it in the fingers very well, and it's in both hands. They usually have anemia, so they do not have enough red blood cells. Some form of osteoporosis, they'll have muscle weakness and even cardiovascular problems. I mean, it's usually start seeing in females, it's more common, and it's usually in their 30s. But it causes joint swelling. You get this pannus tissue that starts to kind of cling to articular tissue because that membrane thickens and it's kind of abnormal. We get scar tissue. And we end up with ankylosis or connecting those articulating end bones. So what's treatment? They'll use steroidal and non-steroidal anti-inflammatory drugs because getting rid of that inflammation decreases pain and inflammation, of course. So sometimes they'll even give immune suppressants, because if your immune system is not if it's hyperactive, we want to calm it down. We want it to stop attacking those joints. So if we suppress that immune system, it calms it down. Tumor necrosis factor is actually shown to block some of the inflammatory chemicals from rheumatoid arthritis. And if it gets bad enough, they may even replace the joints with some kind of prosthesis. This is what the hands of somebody with rheumatoid arthritis looks like. Their fingers are drastically dismembered. They are misshaped. This is pretty painful. You can see lots of inflammation in these joints here. Even down here, some inflammation. Here's some inflammation. You can see how those joints are just acting up. It's painful. Let's look at gouty arthritis. While rheumatoid arthritis is more common in women, gouty arthritis is more common in men. And it tends to go after the big toe, that hallux. It's when uric acid crystals get deposited into that joint and it causes inflammation. And that's what causes gouty arthritis. If it's not treated, those bones start to fuse together. So then you can't move that big toe. So it causes a huge problem with walking. Because you think when you push off, how your toe in that joint bends. Well, with gouty arthritis, if it goes untreated, those bones there fuse and then you can't push off to walk. So there's drugs that can treat it, making sure you drink enough water, not taking in too much alcohol or foods high in purines like liver, kidneys, or sardines. So this is gouty arthritis. This person has it on both sides. The right one is worse than the left, but it's in both. And you can see how in here these bones are breaking apart. It's even a little bit up in there. You're kind of eating away at the bones, and it's going to cause these joints to fuse. The last one is Lyme disease. And I'm sure you've heard of Lyme disease. It comes from tick bites. You usually get some kind of bullet. You get this kind of skin rash. Kind of looks like that. You can get flu-like symptoms, brain fog, can't think straight. It can, if it's not caught and treated, it could cause joint pain. It can even cause arthritis. So they treat it with antibiotics. So Lyme disease, that's why they always say if you go out in the woods, go anywhere to make sure you check for ticks every time. So when we're developing, when we're growing, by week 8, we already have synovial joints that look like the joints in adults. By week 8, that is crazy. So their joint size, shape, and flexibility is modified by use. So as those joints get used, they take the shapes that they need to. That's how capsules and ligaments get created to help support that joint. But as we get older, just like everything else we've learned in the body, tendons and ligaments shorten and weaken. Those intervertebral discs, as I've mentioned, like to herniate. And most people start to get some form of osteoarthritis. So if you want to postpone joint pain, joint problems, exercise. Exercise is the number one thing to keep your joints healthy, your bones healthy, and we're also going to learn in the next chapter, muscles healthy. So exercise is key just to keep your body young. That is everything about joints. Thank you for watching. Bye.